and Medical Director at the Princess Alice Hospice in Surrey. And he has set up and chaired clinical ethics committees in his places of work. And he is also a member of the Association of Palliative Medicine Ethics Committee. And he's talking to us today about the ethics of the Liverpool care pathway. Thank you.
Thank you very much. I'm just checking, is that working okay? The microphone? Hello, good morning.
Hello.
Thank you very much. Okay. It's a genuine pleasure to be here today. Thank you for the kind introduction. And for me, having trained in the Midlands and lived in Birmingham for over 12 years, it is a kind of coming home. So it was a great offer when Brian said, would I come along and talk about the ethics of the LCP? And I think the whole day looks great, so it's great to start the day. And the topic I was given, I was really pleased because it is such a hot topic at the moment. Just a little bit about me, as you've heard, I sit across a hospice, I also have a hospital hat and a university hat. And in the same as you guys making day-to-day decisions, you start to look at the ethics of how we reach the right choices, and that's just led to an interest, hopefully a healthy interest in ethics, but it is still a jobbing interest. I'm not a lawyer, I'm not a philosopher, and I'm much more interested in practical decision-making, that side of ethics, rather than the academia of it. Just to admit that I did go soft and I have gone south. This is my patient's catchment area along a lovely stretch of the M25. It's picturesque but a little bit slow if ever you visit it. So what I want to do today, I'm not going to tell you right from wrong, I'm not going to tell you that I'm ethical. Very few facts per se, but instead what I want to do is challenge you on how you reach your decisions by putting a few strands of controversial ideas in there over this session. We'll run through what the LCP is and then pick out two key issues that have come from that in the media around stopping food and fluids and using sedation at the end of life. But it's about you guys making your mind up rather than listening to what I say. In terms of grandma's suck eggs, I think we're all quite familiar with the LCP now, so forgive me for just going through the basics of it. Developed in the late 90s in a response to what was seen as suboptimal care in hospices for people, in hospitals when people were dying, to try and get that hospital model, the patient dignity model, back into the hospitals. And it was kind of a no-brainer as to which was the right way to go, and it had universal support. It kind of just made sense. It gave us quite nice documentation, so we can show what we were doing, good for audit, governance, and it had a checklist built into it, so we were checking the right things, having the right discussions, and reminding us maybe not to do the wrong things for patients at the end of life in that acute setting. Adopted by the vast majority of UK NHS trusts. Before starting the LCP, it's just worth going through the mechanics of it. It's crucial that the team have come together and said, this patient is dying. There's no reversible pathology. We know that that's why they're going on the LCP. It looks like prognosis is hours, short days at most. And it's that crucial bit of identifying dying. It's not about identifying people to go on the LCP that is critical. And some of the language maybe is the start of the thread of this presentation about how we can drift away from getting things put across in the way that patients and families will understand. Similarly, like with any other intervention, staying on the LCP requires ongoing appropriateness to be on the LCP. That's reviewed daily by the medics. A multi-professional team has to come back and confirm it every 3 days at least, and if there are any concerns in between time, a review will happen as to that appropriateness. And as with anything else, if it's not appropriate, we stop using it. People can come off the LCP, and it's just worth reiterating that. Moreover, the LCP isn't the one strand that the patients rely on for their care to be correct. There's a whole host of decision-making that goes on, with a whole host of influences that guide us in our care of patients at the end of life. We've got our professional guidance, we've got the literature, we've got other summaries, guidelines like the Palliative Care Formulary that will give us the information to be trying to tell us what's the right thing to do for this patient. And all that based in the expertise of you at the patient's bedside, which is the thing that makes the decisions. It's you, not the piece of paper. And if you decide to do something different to the piece of paper, I would argue those variances demonstrate better practice in that individualised, tailored way. So we've just got to put it in that kind of context. So just to try and summarise that, the LCP is a map, it's not a TomTom. It doesn't tell you what to do, it just shows a whole host of options and you pick what the right route is. So, as I said, it was well received when it first came along, and the literature tended to support that. Healthcare professionals and the rest were saying this is great, very few concerns. That was until about 2007, when there was a bit of a ripple, and there was a big rewrite of the LCP. It took 2 years to come out with version 12, which was then confirmed as really the most robust version, and all those earlier criticisms seem to have been ironed out, and it really did look correct. Obviously, last year, those views swung around, and the mushroom cloud went up over Liverpool and most of the rest of the country as well. All on the basis of a consultant neurologist who described it as the death pathway in an RSM, Royal Society of Medicine presentation, which he then went on to put into the Daily Mail. And this caused a kind of a feeding frenzy around this terrible thing, the LCP. We all saw these quite chilling headlines around what it was alleged the NHS was doing with the LCP and killing off its patients. Horrid. And all this unhappiness was really unnecessary because it was the wrong debate that was being had in the media. It was about yes, no to the LCP, whereas I've said it's a piece of paper, it's a means, not an end. And everyone had got lost sight of what the argument needed to be about. When you listen to what the patients and families were talking about, they were talking about poor care, either despite people being on the LCP or because health professionals were misusing the LCP. Some of it actually sounded like just the difficulties of end-of-life care that were generic issues, and it maybe wasn't even bad care, but it all got blurred. It wasn't quite clear which bit was doing which, and everyone was just focusing on the LCP. There was lots of misinformation that was put out there. They said certain things had to happen when patients were on the LCP, food and fluid had to be stopped. Again, all these things just weren't true. And when we went out as the Association of Palliative Medicine to try and put the other side of the story out in the media, we were not only actively blocked in that the media wouldn't take on our message, they then went to our website. I don't want to use the word hacking, but there was some suspicion, because some of it was the confidential site, and they were then misquoting bits from our website to fuel their side of the argument rather than get the truth across to the public. So it was really quite an uncomfortable time as to how that was all being followed up. Pressure built, though, and issues around from the Freedom of Information Act when it was revealed that over half of trusts were getting money for putting people on the LCP. You could see it slipping away. Public opinion was just being eroded to such an extent it was just about lost. There was a kind of a rallying call. The BBC and the Independent started to put a bit more balanced information into the media debate. The Association of Palliative Medicine did a media offensive, a charm offensive, and got a few more positive messages out there. But by this point, the battle was lost, and the inquiry was being set up by Norman Lamb. So Julia Neuberger is about to report kind of now, today, any day soon. I was quite happy that it didn't come out yesterday, because that would have really been a headache. But she's going and looked at patient views and everybody else that could consider themselves a stakeholder, looking at the specific issues like complaints and payments, and bringing it all together with the literature to try and come up with some recommendations, which you will hopefully hear very, very shortly. From my point of view, what are we going to do about a problem like the LCP? Well, kind of nothing, because I don't see it as an ethical problem at all. As I was alluding to earlier, it's the care that matters, not the documentation. It doesn't matter where we write it, it's what we do that matters. And that's the bit that we've got to focus on. And I guess we can bring everyone together and say, yeah, we need to fight about the LCP. Let's fight together to get care better. And that bursts the bubble and takes away all that anxiety. So we want to be careful, because the complaints were about poor care, and we can't condone that. But that was the whole reason why the LCP was brought in. So there's a kind of a perverse circular argument in there. And we can't blame the LCP, as I say, because it's a piece of paper. We've got to look at the healthcare professionals and the support they're getting to deliver it. So, no LCP ethical questions, but there are lots of other ethical questions there. Why is care at the end of life so variable in hospitals? What happens to tools that are misused in hospitals? Do the press have a responsibility when they go misinforming the public and creating all that kind of anxiety? There is this mismatch about public expectations about care being perfect for everybody and it's all just ideal, and there's a little bit of real worldness that's maybe missing there. And then there's political pressures that are out there with rationing, in that the government are very clear that they want third sector to fund palliative care, but they also then criticise that we haven't done the whole job for everybody just perfectly. And again, there's these mismatches in there as to what's going on. So, is the LCP perfect? I think you're all going to go, well, obviously no. But possibly, care in hospitals is better as a result of it, even if there are those problems out there. Because, as you said, the care was poor in the first place, that's why it was there, and there are the prompts and the discussions and things that happen only because of the LCP being there. The fact that we are having these discussions is because the LCP has got us to record everything, and these things have only come to light because those records were there. If you go back before the LCP, that was happening under the waterline, unnoticed. And then by having the LCP, it has brought up in terms of education, in public awareness, end-of-life issues. So you could say there are many positive bits, even allowing for that pocket of not quite so great. So where did it go wrong? This is where I'm going to lose you, because I'm going to blame us as healthcare professionals. It's not the LCP, it's not the patients, it's not the difficulties of end-of-life care, it's the fact that we don't always get our clinical or legal or ethical bits quite right, and that then creates some of the problems. So it may be that we don't make great decisions. When I chat to the junior doctors in the hospital as to why someone's not for CPR, and they tell me it won't work, and I ask them for the evidence base for that, they look at me like I'm odd. They don't know the particular figures for that patient, let alone the figures for patients in average. And they haven't worked through those things. They've just made a lot of presumptions. And you can see why families asking questions of people like that, it all starts to erode confidence. And if they don't know the facts, they can't have the right discussions. So the two particular bits that people have the most ethical concern with from the LCP is this bit about withholding food and fluids and sedation. And they're the two bits I'm going to go through in turn. Okay? So, the first one is, should we use food, and in particular fluids, at the very end of life? Good idea or bad idea? Now, there may again be an easy, obvious answer to that in what we think looks right, but the decision making is always going to be complex, individual, difficult to make. But in the hospital, I'm reeled out on the ward to say, can we stop the fluids here? Or a patient in the next bed that looks very similar to me, can you tell them they have to have food and fluids? And it's this wanting to have a confident black and white answer which unpicks some of the clinical processing. I'll be in the hospice and there'll be a set of colleagues from downstairs will run up and knock on the door and go, the family are wanting food and fluids for this patient at the end of life. Go down and sort it out. And if you look at it, kind of we've lost some of our balance around some of these issues. It's seen as a kind of a strange request. How could they be asking? And we know it won't work. And we've lost that holisticness. We're looking at it biomedically won't work. We're not looking at the bigger picture. And we're saying they can't demand this, and autonomy and conversation and negotiation goes out the window. And the whole bit about just doing something simple like a trial and seeing what happens, and like we would do with any other intervention in palliative care without a clear evidence base, we suck it and see, is just too awful for us to consider. And then the decision making that underpins the decision either to or not do fluids is really quite sparse in the notes. It's not clear what the rationale were for those decisions. So we've kind of left ourselves vulnerable in how we look at that. And the key bit is to say there isn't a fight for anybody. Between all of us, all we want to do, we're all on the same side, is get the care for that patient today as right as we can. And that will please everybody. There's nobody that's going to have a fight with that. And if we just bring people together in that way, it's really quite straightforward. And what I'm going to try and suggest is not difficult. Though I think sometimes it feels it. So, first bit, due to any treatment, absolutely everyone, is really simple. And there are three questions. This is kind of a remashing of the four principles into something that works at the bedside. The first question is, could this treatment work? The next question is it in the cupboard? And the next one is, does the patient want it? And that then solves the whole problem. So it's the Fab Three rather than the Fab Four of ethics. So that first question, how can I tell if it works? Well, I would go to the evidence base. That's what we do for all our other interventions. And I would either know that it will work, in which case I'm obliged to offer it, irrespective of what I think. I know it won't work, because the evidence tells me that, in which case I can't offer it, even if people want it. Or if I'm not sure, I do a trial, or refer to somebody else for them to do a trial. So it's really quite simple for us. The evidence does it for us. The next bit, is it in the cupboard? This one's not difficult because we know if it's there or not. But what's not nice is that sometimes it's about rationing. We've got it, but we don't want to use it for a bigger reason. Not about that individual patient in front of us. We're not putting that patient first. We're looking at the service as a whole and patients as a whole. And we come to that speech bubble of the small chance of benefiting you isn't worth the hassle for all the other patients and staff, which really rubs us up. We don't like hearing that, but possibly that is some of it. And there's this conflict between looking at the bigger picture, which we have to do, particularly as a manager or looking after a service, but then individual patient, there's a conflict because you can't do both. You can't have your cake and eat it. The last one is, again, not a problem for us as a healthcare professional, it's a patient problem. Do they want it? Really simple. If they've got capacity, they say yes or no. And if they haven't got capacity, through the Mental Capacity Act, best interests, they should be able to match that yes and no just as well. So really, I don't think it's too tricky. So, having said how simple it is, just for fun as a kind of a show of hands, who of you here think in your practice you would ever withhold or withdraw treatment? I've got 1, 2, 3, go on. So there's a few, but not a many. I'd be surprised there's so few, so you might just be waking up. So if we didn't this afternoon, we may have got more. Or you might just be scared of me because I've been going at speed like a pressing a load of slides to get through. I'm going to say that withholding withdrawing treatment never happens, full stop. Because if you go back to those 3 questions, the answer is it won't work, it's not available, or the patient doesn't want it. Which is very different than taking something away from somebody as the Daily Mail sees with the LCP. And again, just work through those. What do I mean by won't work? Well, I've tried it, they've been on antibiotics for the last week, the white count's going up, the CRP is going up, the patient's getting less well, we're sending them to the hospice after the weekend from the hospital. Those antibiotics are not working. When we stop them, we haven't taken anything away other than the toxicity of the treatment. Interestingly, the hospital keep them on the antibiotics over the weekend and get an extra dose in IV just before they come to the hospice for their final hours. Because just inside their head they're thinking, but it must still be working. Everything's telling them that it's not, but they can't stop it because they're kidding themselves. They can't let go of that. Sometimes just talk about it with the patient and they'll say, that's not a meaningful gain to me, it doesn't sound like it's going to work, so it's just a joint decision not to run with it. The more contentious one is where you're so sure it won't work, you're not even going to offer it. And I'll come back to that one. But the example I'm giving, which maybe isn't contentious, is a patient with end-stage heart failure, right at the end of life, clearly fluid overloaded, very symptomatic, final hours. Putting up a drip in that patient is not a treatment. So it would actually be only counterproductive. So it's not on offer in that patient because it's not a treatment. The next 2 are important to separate out as different reasons for not doing a treatment because there are maybe different responses that go with it. The first one is saying I haven't got it in the cupboard. So I say, I haven't got it now, so no, you're not going to get it. If I have an adult that wants TPN at home, I haven't got a system for delivering that, so it's going to be no. It's important though, but I've got a question, why haven't I, and should I? And there's some follow-on from that. And in very occasional cases, we do manage to set it up. So there are issues there. The next one is clear, if the patient refuses it, the treatment's not happening. Again, nothing to do with us, that's the patient decision. But what's important is the treatment still may be quite effective, and it still should be on offer if the patient changes their mind. But if you haven't recorded which is the reason why people aren't on it, in the follow-up you won't be checking those things. So we just have to be really clear about that decision making. What I'm suggesting is that patient choice is quite important in this. But I've got to be careful and be guarded in saying choice isn't have whatever you want whenever you want it. It's not here's the B&F, pick a drug. You have a professional responsibility. And the patient autonomy is from what's on offer and from the impact it has on others around them. So I was buying a car a few years back and I had free choice, or so I thought, but I did have to please my wife and my bank manager, and so in doing that, maybe the car I liked the most wasn't really in the mix. I ended up with a choice between, I got the Civic if you're interested, the Golf and the Civic. But that was the reality of it. In the same way for patients, when they make a decision, they are connected to their family, other patients, the healthcare professionals. There are wider implications, and that has to come into it. And then that bit about, we need to work out, what are we offering? The mistake is when the patient is in hospital, you say, do you want resuscitation? They say yes, and then you go, oh, I don't think you can have it. It's this bit, the first thing we need to work out is it a treatment that's on offer before you start getting yourself in a corner? And so the key bit is look at the evidence base and check how is someone going to be actually able to offer it before we start getting to that choice. The contentious one was when I was saying, maybe you're not going to get a choice because I'm not going to allow that, because I'm sure it's not going to work. And I just want you to think how you decide what futility really means. Futility is often written on CPR forms, not why is it not on offer? Futile. And when I ask people what they meant by futile, they say won't work. I go, great, what does that mean? In what way? How often? And people again, I don't know. You've got to work out, if you were saying it, what would you do? So would you talk about numbers? When we talk of giving treatments, we are very clear in using numbers, even though they're limited. The evidence-based, number needs to treat, Cochrane reviews, all about numbers. So we should like numbers. And we can measure it, get a statistician, it's very clear. And historically, 1 in 100 has been used as a kind of a cut-off for futility, arbitrary. But then that bit about, if I said food and fluids worked in 2 in 100 patients, how many of you would be happy to say, yes, that means it's not futile? So the number is a little bit uncomfortable, isn't it? So then I need something more grown up and more, kind of a bit more mature. I'm going to say it's the nature of the benefit that matters. It's that meaningful benefit. Forget the numbers. That's great, a lovely case-by-case judgment, but who's going to make that decision? And how are they going to make it? Which is the domain that matters? Or I'm going to pick somebody out of the mix as the best-placed person to make that individualised, meaningful assessment. It's going to reduce down to the family, the patient, and then possibly the family, and we're possibly last along that list, which leaves us a bit vulnerable again in working that out. So just as kind of splitting it in a different way, to slice it the other way, I can look at food and fluids in terms of survival, I can look at food and fluids in terms of symptom control. I could go a little bit more outlandish and say, what about being seen to try our best, do everything just in case? If that makes a patient's final days feel better for them, their family, and reduce bereavement issues, would that be a measure of success? Less bereavement distress? It's a bit spooky to think of using food and fluids as that. You all went a bit quiet then, even though you were speaking before. It's very noticeable. Wow. So, scary bits. Could food and fluids at the end of life make a difference? Well, there are predictable problems that you'll have without food and fluids at the end of life. They are there. We can't escape those. We know they're about. The ones that I think I've highlighted, the ones that you're going to worry about most: confusion, thirst. Mouth care will not help thirst. It will help dry mouth, but it won't help thirst, and vice versa. And then, as we mentioned, the anxiety and all the psychosocial issues that are so important. So, I've made it emotive. Thank you. Let me get away with it so far. So what I need to do is to debunk it with a little bit of evidence to make us more comfortable about what we're doing. If we go to the Cochrane review, as was predictable for many Cochrane reviews in palliative care, it doesn't really answer the question. The studies aren't out there to give us a clear enough answer. It describes a whole host of ways food and fluids can be done, but it says we don't know whether it causes more harm or good. So we're a bit lost. The answer is we don't know. So if we don't know, we trial it or send to a colleague. If I look at my professional body, the GMC, and their guidelines, in the same way, they are clear that not giving food and fluids at the end of life can cause problems, and giving food and fluids at the end of life can cause problems. So I'm damned if I do and damned if I don't. Again, not clear, trial it, or refer to a colleague. If you look at the more recent data following the Cochrane review, there were a couple of key trials from last year. One sold by the author as a randomised controlled trial, though free fluids and 100 mils of parenteral fluids were in the control arm, so it doesn't really fit. Suggested as that if it is an RCT, we could say that's the best data, which said there wasn't a benefit of food and fluids at the end of life. When you actually look at the trial, there was a clear trend, and it was stopped. If it had gone on for another day or two, there would have been a statistical difference in terms of less confusion with people on more fluid compared to a lower amount of fluid. And the larger observational studies still consistently show clear benefit from food and fluids at the end of life. So you can take your pick with that. I'm edging towards no on paper, but not sure. If you look at the other side of the seesaw, see the tipping point, the harms that we worry about, those two trials are very clear, no harm from the fluid arm. So if we're saying there's no harm, the chance of, or the need for any big benefit gets a lot less because there's nothing to counterbalance it. Now, I'm going to get into even more dodgy territory now by talking about the legal position. Strangely, a family, patient, demanding food and fluids would have a very strong case in the courts to get it. If they have capacity, you're on thin ice if you're going to say no. If they don't have capacity, what we know is in persistent vegetative state, minimally conscious state, you are obliged to carry on with food and fluids until the courts say no. And on the back of case law from the end of 2011, technically, possibly anybody lacking capacity, you need to go to the courts to stop it, which seems really quite bizarre. This sanctity of life argument is very prominent in the courts, but it isn't going to really work in practice. Courts will be swamped, there'll be a lot of clear over-treatment as a result, and arguably with best interest we shouldn't need to go through that process. But with these historical statute, which kind of trumps in terms of its weight, but newer application of that in terms of case law that has us on an edge. And perversely, if you look at the Tony Bland scenario, that being replicated today, he wouldn't be allowed to have his food and fluid stopped by how the courts look at it now, whereas that was the test case that led to the statute. So I'm kind of rubbing my head thinking, how can that make sense? If any of you have gone to your NHS lawyers and asked them, can I stop food and fluids, you should get these 4 responses. You can only stop food and fluids if there's a valid refusal, quality of life is so clearly intolerable, the treatment is impractical, you can't manage to do the food and fluids, or the patient's dying so quickly food and fluids can't have an impact. Which is a very tight set of criteria, but that's what they reduce it down to at that point. And this is the problem, if you ask the lawyers, beware what answer you get. So if I move swiftly, he says, to sedation. Is sedation good or bad at the end of life? Differing views out there. I'm going to suggest, like I don't withdraw and withhold treatment, I never sedate patients at the end of life or at any other time. And I'm going to kind of say that it kind of makes sense that we wouldn't, because the human conscious state is the whole essence of being human, that being awake and aware. So we would be doing everything that we can in our power to maximise that. What we would never do is chuck that away. So that's the premise that I want to put in there. But to make sense of it, we've got to work out what we mean by this word sedate. So if you're walking down the corridor in the hospital and you hear a member of staff say, we're going to go and sedate the patient in room 18, what in your head are you thinking is going to happen? It might be different if you put yourself in a psychiatric unit, or in a medical unit in an acute hospital, or in a hospice. And therein lies some of the problem. If you look at it technically, any suppression of physiological function is sedating. So I could say, if any of you are on antihistamines now for your hay fever, you're being sedated, but that's just balmy. So we're not going to use a technical term. I'm going to put in there that in palliative care, I would argue, where it's the non-sedation use of drugs with potentially sedative side effects. Bit chunky, you can see why it doesn't work. And the other one is flattening patients. And I think if we look at what lay people think, they're very clear. So when they're reading the Daily Mail, sedation means knocking somebody out. So we have to be very careful about that. And equally, within our own ranks in palliative care and certainly in the acute sector, there are colleagues that may want that, families that may want that, patients that may want that, and equally a number that would think that would be the worst thing that could possibly happen. And you've got this polarised view. The impact of that is that patients don't get the right symptom control because we're worried about doing sedation, so we don't do the right treatments. There's